I just want to say what an extraordinary meeting I think this is, to have patients and caregivers come together and talk about diseases together. It's just exactly what we need more of. And it's so easy to lose sight of what is important and what are the critical elements to make disease go away and make health return. And I just want to applaud the organizers for putting together an extraordinary meeting. So I want to talk to you about a variety of things today. I want to say at the beginning, this is a U.S. government facility, and I am a U.S. government employee. So I actually am one of the U.S. government employees. I have no conflicts of interest, honest. And I want to tell you that I'm very proud to work at a U.S. government facility, because this facility and this institution is really available to all people of all the world. And when people come to the NIH, they are eligible for care regardless of their country of origin, regardless of their citizenship, regardless of the money. So I want you all to be thinking this is an institution that you have some access to and you have some ownership of as a citizen of the world. We also have many educational opportunities for medical students, for scientists, for doctors, for visitors, and I hope that you will contact me and try and take advantage of those. I also want to mention one of the newer things that we have been doing at the NIH in the last couple of years, and that is to create a comprehensive program for non-malignant immune diseases. And by that I mean we are doing bone marrow transplant and gene therapy and management and induction and genetic sequencing all as part of one program, so that we've got our transplanters talking to our doctors, talking to our gene therapists, and all of the patients are managed together by one large group. And I think this is, by the way, that means pediatric and adult, all one center, so that we are now trying to make sure that we are taking advantage of all of the wisdom that all of our groups are developing to make sure that we work together. Okay, so what are the non-antibody deficiencies? And it is nice to go after Charlotte, because she's really focused on the antibody deficiencies, but with also some of those non-antibody problems, that granulomatous stuff. And you heard Vilmer talk earlier about the how to use antibodies. I don't care about antibodies. We're not going to talk about antibodies, so just forget about it. We're infusing nothing here. So I'm going to talk a little bit about bad antibodies. I'm going to talk a little bit about the STAT1 gain-of-function disease, which you've heard a lot about already today, and I suspect also yesterday. And then I want to conclude just for a moment on some issues in chronic granulomatous disease. And I'm going to talk about management for patient care. The most important and overlooked thing, and I want to emphasize what Charlotte mentioned, and that is antibiotic or antimicrobial prophylaxis. Now, many doctors have become very nervous about giving antimicrobial prophylaxis, and I think that's too bad. In HIV, nobody thinks that it's a bad idea to give prophylaxis, and I've just made a list of all of the prophylaxis that is standard in HIV. What's standard in primary immune deficiency? Not near as much. And the only places that we've got real data are in chronic granulomatous disease. Everything else is pretty much made up piece by piece. The paper that Isabella Quinte's group published is critically important because it begins to look at the population that we care about. There is, for instance, here is the disease that created the field of primary immune deficiency, X-linked A-gamma globulinemia, and there is still no consensus about whether people should get therapy beyond immune globulin. That is crazy. How can we be this far into this field and not know the answer to questions like that. We have not been working hard enough together as a community to develop those answers. So I'll just emphasize here exactly what Charlotte said from a different publication. Here is using azithromycin. This is 250 milligrams daily. Most people can tolerate that dose. And at 250 milligrams daily, you can see this is the proportion free of an exacerbation. Many fewer people got sick on azithromycin than on placebo. And there were problems. Deafness, transient, reversible deafness or hearing loss occurred in 5%. That is more of a problem in the elderly than the young. But the improvement in lung infections and exacerbations is dramatic, and it is very safe. It also, as an aside, is very good for all-cause mortality. And when you look here in several countries in Africa, the rate of all-cause mortality was dramatically reduced when you gave azithromycin. You can see it goes down. Now, there is, as we say in the United States, there is no free lunch. And there is a price to pay for giving these drugs. And there is some increase in resistance to azithromycin in strep pneumoniae. Whether that is important for the diseases we're talking about is a slightly different issue, but it is true that you will get some antibiotic resistance if you use more antibiotics. That does not mean you should not use them, it just means you need to be aware of it. Finally, well, what is it doing? And we think about antibiotics as being good at killing bacteria, and they are, but they do more. And here are some examples of how the antibiotic, here CAM is clarithromycin, a close relative of azithromycin, is actually reducing the production of tumor necrosis factor, interferon gamma, and increasing the production of IL-10. That is, these drugs may have biologic effects of their own that are important in their activity. So I want to make sure I emphasize that one of the most important things that you can do in the care of patients with recurrent infections is try to prevent their infections. And antibiotic prophylaxis is proven in some primary immune deficiencies. Azithromycin is very good for lung disease. The mechanisms may not be as simple as they sound, but it is very effective in other forms of chronic lung disease. And yes, there are some risks, but there are always risks to things that we want to change. Now I want to move on to anticytokine autoantibodies. Here is a schematic. Here is a B cell in the middle, and you can see that B cells are making these antibodies that are blocking a whole variety of cytokines. I will not go into all of these, but everything from erythropoietin to G-CSF to interferon alpha, GM-CSF, interferon gamma, and IL-12. There are lots of acquired autoantibodies being produced by B cells. Very few of them are tested for. Very few of them get diagnosed. That is not good. Now, my own interest is around the antibodies that are involved in the interferon gamma IL-12 pathway. As you recall, macrophages get infected with mycobacteria. They produce IL-12, then that leads to the production of interferon, and that leads to the killing of mycobacteria through the interferon gamma receptor. Here in red are all of the mutations, or not all, many of the mutations that are known to be associated with mycobacterial susceptibility. And the patients who have defects in this pathway get infected with mycobacteria, as well as some other bacteria, gram-negative bacteria, gram-positive bacteria, fungi, and viruses. That's what is seen in the genetic disorders. In the acquired disorders, antibodies that block interferon gamma or IL-12, these antibodies mimic defects in the IL-12 receptor or defects in the interferon gamma receptor and downstream signaling, and these are acquired somewhere typically in adulthood. What do they look like? The anti-interferon antibodies tend to be much more common in people in Southeast Asia, probably because of HLA associations. And here is a woman who at age 60 showed up in the United States with these skin lesions that were due to infections of bone that were coming out through the skin. She had been very healthy up until then, so this was an acquired problem that led to mycobacterial infection with Mycobacterium avium. Now, these are important things to identify because unlike genetic disorders, which require either gene therapy or bone marrow transplant, these are acquired antibody disorders, and you can treat them by getting rid of the antibody. In this case, we're looking at the use of rituximab, as Charlotte discussed, for the treatment of granulomatous disease. Here we're using it to eliminate B-cell function, and you can see that the level of these autoantibodies goes down with treatment, and if the patient develops higher levels and has recurrent disease, you can treat again, and it goes back down. And this is a very attractive way to treat these diseases, and I think that it is wise, if you can, to give these drugs like rituximab early after diagnosis. That is, you can treat people without using rituximab, but it takes longer, and they have more exposure to drugs and more time being sick. They get better faster when you use rituximab. There's another set of autoantibodies, though, that are even more common, but less frequently looked for in the people who have infections. And these are the antibodies against GM-CSF. And I just want to remind you, GM-CSF is made by many cells, but it acts on myeloid cells, that is, the alveolar macrophages, monocytes, macrophages, neutrophils, as well as T cells. And antibodies against GM-CSF then block its ability to stimulate the macrophage in the lung. And the macrophage in the lung has many different jobs. It has to digest all of the things that we inhale. It has to digest all of the fluid that we put into our lung, as well as turn on many other cytokines that stimulate lymphocytes and other macrophages and monocytes. Well, these antibodies to GM-CSF are relatively common, and they can cause at least 3 distinct syndromes. I'm interested in the infectious syndromes, and so here, this is nocardia in the brain, and that is associated with the development of these antibodies to GM-CSF. And we have encountered this now in people from around the world who have nocardia that is disseminated throughout the body. Interestingly enough, they go on later to develop the lung disease that is associated with antibodies to GM-CSF, which I will show you. So one manifestation is brain nocardia infection. The second one is brain cryptococcus infection. So this is a fungus that lives in a variety of places, in particular in Western Canada and in Australia. I cannot tell you exactly why. I know Stu Tangi will tell us about it. But these fungi live in only a few places, and this particular fungus, Cryptococcus gattii, is the one that people who have autoantibodies to GM-CSF develop. And you see here these brain abscesses that got worse and had to be cut out. And here on the biopsy, you can see the fungus there in the brain where it caused disease. This is really strongly associated with these antibodies to GM-CSF. Again, these people, years after the infection, can develop the most common complication of GM-CSF autoantibodies, which is pulmonary alveolar proteinosis. And here you see a typical example of it. This is called crazy paving because it has these lines in it that look like street paving stones. And you see here what it looks like on the CAT scan. And on a biopsy, you see these things that are called cholesterol clefts because the cholesterol that's in the fluid in the lung gets removed when the lung tissue is processed. This is a typical example of pulmonary alveolar proteinosis, and this is the most common manifestation of the autoantibodies to GM-CSF. Now, whereas people who have infections get treated for their infections, and they typically resolve, and in rare cases, you might decide to try and use rituximab to get rid of the anti-GM-CSF autoantibody, it's not usually needed. In the lung disease, this is a very controversial question right now. How do you make people better who have this severe lung disease? And so Ko Nakata from Niigata in Japan has just put out the first prospective trial looking at inhaled GM-CSF for pulmonary alveolar proteinosis. It just came out a couple of weeks ago. And here what you see is that the alveolar arterial oxygen gradient, that is how well oxygen is transferred in the lung, actually goes down when people are receiving GM-CSF more than it does when they have a placebo. That's a good thing. You want that to be better. And here you can see an example on the CT scan of how much infiltration there is before and then how it improves after inhaled therapy. So these autoantibodies are really quite complicated. They copy Mendelian diseases, especially for the interferon gamma and IL-12 circuits. I just want to point out that these antibodies are common in thymoma, but in thymoma they are not so clearly associated with infection. Whether that is because thymomas lead to different kinds of antibodies or people get preoccupied with the cancer instead of the infection, I don't know. The anti-GM-CSF autoantibodies are seen in several different settings, and we're still trying to figure out how we should treat those in the future. They do respond to rituximab, but whether that is necessary is not clear. All right, so I'm just going to mention briefly STAT1 gain of function because it's been talked about a lot. It's a very much more common disease than I think we ever anticipated. And it has many, many different manifestations. The ones that were initially recognized are shown here: severe cutaneous, severe skin fungal infections, typically with Candida, and disease of the mucous membranes, chronic mucocutaneous candidiasis. But it turns out to have a much broader phenotype than that, as shown very clearly in the really huge and fantastic paper by Ann Powell's group a couple of years ago. It's a dominant immunodeficiency with a variety of infection susceptibilities beyond Candida, as well as cancers, autoimmunity, and CVID. Now, the attractive idea here is to use JAK inhibitors, and it makes very, very good sense. The mutation is here in STAT1. Here, these that have the star in them. The JAK inhibitors come in and block JAK activation of STAT, and you can turn this down dramatically. It makes very good sense. And it does work in vitro and in vivo. You can block STAT1 activation with these JAK inhibitors. And as was shown earlier today, it's very good for the autoimmune phenomena. Here, this young woman had alopecia that resolved on therapy. While she had alopecia, she also had chronic mucocutaneous candidiasis that also resolved on the JAK inhibitor therapy. The candidiasis came back when she stopped. The alopecia did not. One of the problems with all of the reports about JAK inhibitors for STAT1 gain of function is that they don't have very long-term follow-up. And I think this is a major issue, and as I have spoken to many of the groups that have been using this, Many of the patients are doing well, but also many of the patients are losing control with the JAK inhibitors over time. And I don't know whether this is an issue about dose or about host response and upregulation of other pathways, but it's very important that we, again, come up with a prospective study to tell us exactly what is the role for these JAK inhibitors in the treatment of these patients. I think it will be most effective for the autoimmune phenomena and maybe for the candidiasis, but it may not solve all of the problems. So these Ruxolitinib and other JAK inhibitors, they're well tolerated. They normalize the STAT phosphorylation signature, as Olaf Neth showed earlier today, but I'm not sure that they will be a long-term answer, but I hope they are. I'm not positive. Bone marrow transplant is still a problem. Now, I think I'm going to finish here. I'm just going to show one quick element in chronic granulomatous disease and finish, and that is to say that in chronic granulomatous disease, we now know the critical element is to control both inflammation and infection at the same time. Nowhere is this better illustrated than in liver abscess, as Josie was talking about and Charlotte was mentioning. Patients with chronic granulomatous disease get a variety of bad liver problems, including infections and nodular regenerative hyperplasia. And when you have an abscess, it is best to treat that with steroids and antibiotics at the same time and not surgery. And if you look here at survival, those who get steroids plus antibiotics alone do much better than those who got surgery or radiologic interventions. So I will just conclude by saying that we have to really think hard about how we use antibiotic prophylaxis. I think it helps a lot with recurrent lung infections, and it may help with more than that. We need to be thinking about these autoantibodies and how to attack them. We need to be trying to think how to use JAK inhibitors in these diseases, and we desperately need prospective studies. We need to figure out what is the right in vitro target to know if we are doing the right thing. I thought it was very interesting in Benedict's talk earlier today, you heard the complexity of does the interferon signature really predict everything? Should you use the interferon signature? Should you not use the interferon signature? How do we know what's the right target? So trying to figure out how these things fit across the lifespan is complex. And as I get toward one end of it and further away from the other, I find myself more confused than wise, but perhaps that is the way it goes. Thank you very much.